My name is Eunice Huang, and for those of you who do not know me, I'm a pediatric surgeon at the University of Tennessee Health Science Campus in Memphis, Tennessee. Jonathan Mizell and I are thrilled to have the privilege of moderating this session on variations in care on the topic of gastroesophageal reflux disease. As you may recall, last week we talked mostly about a very straightforward diagnosis, medical and surgical management of a patient with reflux. Tonight we will be talking a little bit more about more complicated patients, patients with cardiac anomalies, or neurologic patients, and patients who have TEF or esophageal atresia. As you recall, we have 5 very talented physicians and surgeons who have deep but differing experiences with the care of patients with this problem. And so we're going to have this discussion as a case-based discussion, talking about different patients. During the case presentations, please feel free to send in questions via the chat function, and we will incorporate these questions and comments into our live discussion with our panelists towards the end of this half hour. So you are consulted to see a 2-month-old infant that's born with a hypoplastic left heart syndrome. The infant underwent a Norwood procedure shortly after birth and has been in the CDICU ever since. The cardiac team has been unable to give the child to full feeds via nasogastric tube feeding due to vomiting, irritability, and what they say is severe reflux. There has been several episodes of severe bradycardia associated with tube feeds seen coming out of the child's mouth and nose. NJ tube feedings seem to be tolerated well. However, the cardiac team is frustrated with the NJ tube because it inadvertently pulls back occasionally into the stomach or is pulled out completely.
I'll take a first stab at it. I think these are sort of particularly interesting situations, and often we have to be careful because there's somewhat of a provider sort of bias the way I see it, because the cardiac ICU sort of eager to move the kid along and get him to the floor and out of the ICU so the next patient can come in. And so obviously the thing that's in the way of that is that they're vomiting, and often because they're weaning sedation and a whole bunch of other things are going on. And so the other thing that's tricky with this is occasionally they bypass the whole evaluation with the pediatric gastroenterology team to sort of move things along. And so you have to be sort of careful about these consults because of that. I think these are the cases that are ideal for a gastrojejunostomy tube if they need enteral access. But the first thing to keep in mind is these kids can have heterotaxy and can be prone for malrotation. So some of these kids can, particularly if they're heterotaxy, should get an upper GI to make sure there's no malrotation to start. But if that's not the case, or the reason of the feeding intolerance, a GJ tube is something that as a temporary measure for them to be able to get that nutrition and be able to progress with their weaning of meds or cardiac recovery. They often do really well with that.
Then I appreciate that shout out, because they always bypass us to you. And so we appreciate that you recognize the role of us. I think cardiac kids from a medical perspective are really tricky because I think, for example, a lot of times they take out the recurrent laryngeal nerve and they forget that there's vocal cord paralysis and that the kid's aspirating because of that. And you have to step back. A 2-month-old should be able to keep in an NJ. So if they're not, are they retching so badly? Okay, well, why are they retching so badly? And those would not be the right ones for a Nissen if they're retching so much. And again, just kind of getting back to the basics, many times they're running 34 calorie per ounce formula into a 2-month-old, which is triggering the retching. And so you have to look at what is being fed and what formula is being fed and where the tube is, because as Ben has mentioned, there are studies looking at aspiration pneumonia, and if you're in D2 or even more proximal, there's no benefit, for example, to preventing aspiration pneumonia. So sometimes you really do have to go deeper with the tubes. And then the other thing to mention is the retching, which these cardiac babies are often horrible retchers. Sometimes you have to get the retching under control with neuromodulators. So we use Neurontin, for example, to help with the retching, or we'll use Botox as a bridge to get the kid to grow, because I think most of us feel like the key is to get them to grow. And if you can get them bigger, then a lot of these things get better. And so temporizing with Botox, Neurontin, a GJ, changing the feeds around, all things that are helpful for us.
You know, many of these patients, they end up getting an upper GI. They have this iffy malrotation, right? It's not like the classic non-rotation with distended duodenum, but there's this iffy sort of incomplete rotation. Or patients with heterotaxy may have true non-rotation, but then we know that those patients don't tend to be symptomatic. But if you have one of these situations, do you blame the symptoms on the anatomy, or is this still a patient who's refluxing?
I think that's a really good question, and it's super hard to tease that out because I think it's not just an abnormality of rotation oftentimes. Yes, they may have a ligament of Treitz that's displaced. The point of view of those that would advocate a GJ in this setting, because many of these kids, if you do bridge them for 6 to 8 months, will outgrow that reflux, or by then they've gone on to at least their second stage in their palliation. And so their pulmonary blood flow is in a far safer place, and so they're not at risk for sudden death by clotting their BT shunt. However, here at least, because we haven't used the G-tubes with the Korpak or Dobhoff modification with a tiny J-limb, the cardiologists here have had a fairly common complaint that the jejunal limb obstructs the pylorus, and it makes it so that even though you're feeding the jejunum, the gastric juices that they normally secrete still come back up. So I think if you have either a pylorus that's open enough or a small jejunal limb, that's a good option. Or we tend to come down on the side of fundoplication here for those babies, but I think that that's probably a local phenomenon, and I don't have any data to say that that's superior to a GJ necessarily. I'll just say, I do a few things to try to save time on this operation, particularly because a number of the babies that I end up operating on have congenital heart disease. And so in those, I think time is really of the essence. Once you have put in a retractor and altered the outflow of the liver, you really have about 35 to 45 minutes before the liver starts to swell profoundly and the ceiling starts to collapse. So just from a technical point of view, that's an issue. Usually I have everything set up before we start, including the Bookwalter retractor attached to the bed. The flexible arm is already attached so that once we put the liver retractor in, we go. None of that wasting time with the baby insufflator.
Okay, so our next patient is, you're evaluating a 5-year-old child with developmental delay, moderate cerebral palsy, and a seizure disorder. The patient takes about 50% of his nutrition by mouth, which is all in purees, and the other 50% is supplemented by G-tube. The family and pediatrician are concerned for worsening reflux despite maximal dose of H2 blocker. He has been admitted twice in the past year due to aspiration pneumonia, and his parents describe severe irritability with G-tube feeds. He has arching of his back and vomiting. Rachel, let's again start with you as our friendly neighborhood gastroenterologist.
Sure. So I think, as all of you know, these kids often get instrumented. They get baclofen pumps, they get rods put in their spines. Their anatomy changes over time. So I guess the first thing we would say is, why is this kid all of a sudden getting worsening of reflux? Is the G-tube location migrated? Is this too close to the pylorus now? Like, where is that G-tube relative to the antrum, or is it somewhere else? Would be the first thing that I would want to know. And then are there been any other changes? So changes in his seizure meds, neurologic status, is there a shunt in place that I need to think about those things? And the other thing that we find is, as I mentioned, we're running feeds very thick these days. And sometimes families have gradually increased their free water. So they're like, say they're drooling more. So then they want to give more fluid, and then they drool even more. And then we're in this vicious cycle where we're giving more and more fluid into the stomach, which thins the stomach contents, which makes reflux worse. So, this may be one where, if you're not sure if the aspiration pneumonias are related to aspiration of saliva versus gastric contents, the GJ for a period of time to see if you can modify the respiratory trajectory, I think would be really important, because also many times they are really getting aspiration pneumonias from saliva.
Can I open this up to our surgical panelists? If you saw this patient in your office, what would you offer them, or would you want additional studies?
Completely agree with Rachel on this. I think this is definitely not a child that I would offer an anti-reflux operation to. Many of these children are aspirating their saliva, and that's really the thing that needs to be addressed. Feeding them distally, I think the best way to go, and the question is, which of the choices would you like to take? We've really gotten away from the esophageal gastric disconnects because technically a more challenging operation, but also fraught with more issues post-operatively. I think just so many additional issues that can be obviated by a much more simple intervention, either a GJ tube or this omega jejunostomy. I think both are good options in this setting.
Ben, in Boston, do most of these patients end up with a GJ tube? Is that your first line procedure for them?
Yeah, for the most part, unless they have a contributing sort of hiatal hernia. Or another compelling evidence to pursue a fundoplication. But we really drag our feet with these as well for a fundoplication because of all those reasons that sort of Rachel and Matt highlighted. It is sort of tricky, especially if they've had a fundoplication in the past, or if they already have a G-tube. I think it's a good sort of strategy to start with converting the G-tube to a GJ tube and sort of seeing how things go. And if the problem then becomes the maintenance of the of the GJ tube as a single standing unit, and you want something a little easier to manage at home without having to come in for fluoroscopic replacements, then that omega jejunostomy becomes attractive because it can be managed as with like a button type G-tube as well, with exchanges at home or in the office. And so that is definitely something we consider.
Do you find that these patients, because often are contracted and maybe scoliotic, are more challenging to place GJs?
Occasionally, the hard work can be challenging with fluoroscopy, but not necessarily. I actually think it's harder doing this in some of these kids just because the ports and the number of ports you have to put in, and the costal margin is often very narrow. And the knees are up and bent, and your axis, I think it's harder to potentially place to do a Nissen in some of these kids than it is to do a lap GJ.
Rachel, let me ask you another question about kids with developmental delay and are on multiple medications. It seems to me that dysmotility is a big component of GI dysfunction. Do you find that esophageal dysmotility or gastric motility is really contributory to a lot of these kids we see with retching and vomiting and aspiration?
I think motility is a huge problem. I think it is a really big issue. Again, just kind of getting back to the lung transplant population, when we looked at what predicted lung transplant failure, it was actually gastric dysmotility, not reflux. And I think what we're finding, and I'm sure Ben can speak to this in the esophageal atresia population as well, but both esophageal stasis and gastroparesis or delays in gastric emptying, I think, have a big upstream effect, not only on symptoms, but also on chronic lung disease. Treating the motility is critical. And now, for example, in the transplant population, patients are getting every 3 to 6 month gastric Botox to try to preserve their lungs. So we are pretty aggressive about treating the dysmotility. I wish we had better medications. Prucalopride is on the market now, so that is a big win for us. But before that, we don't have a lot of great options. So I think we used to think a lot about dysmotility, but kind of throw our hands up and say there's nothing we can do about it. But at least now newer drugs are coming out. So, and same thing with the obstructedness. We think a lot about unwrapping, but there's also a lot of GEJ obstruction related to Nissens. And what we see is stasis over the Nissens that ultimately causes lung damage and aspiration. So I think now, as part of our due diligence for the post-fundoplication, for example, aspiration pneumonias, we need to look for not only unwrapping, but make sure those kids get contrast by mouth. And we do 10-minute delayed films looking for barium columns, or do high-resolution manometry to look for that obstruction, because that esophageal dysmotility related to EGJ obstruction is a big deal for us.
The point is that, everybody watching this will immediately identify with how difficult a population this is. And I don't mean just the population of patients, but the population of parents who are involved. And I really don't know how I would deal with it if I was the parent of a child like this. I think it's extremely difficult, which makes it even more difficult for us to be really honest and open about our options, because the parents come to us really looking for a solution. Sometimes the pediatrician had told them your kid needs a fundo and things may get better. And we have to be really honest. We have to identify the problem. If the problem is failure to thrive, poor weight gain, poor nutrition, putting the child at risk for infections, etc., a gastrostomy may be enough. If the issue is trying to decrease hospitalizations, trying to decrease aspirations, etc., we have to be honest that we don't have really any solution right now that has been proven to accomplish this. And so I think, one thing we don't think about often is when these patients come in and we know their life expectancy is quite limited and they come in with a massive aspiration pneumonia, we as a medical establishment automatically fire off a PICU admission. But, would it not be reasonable to discuss palliative care in a patient like this before we immediately go to see acute care and escalation, antibiotics and hydration? And I just don't think we do it enough.
I would also just add one thing that we didn't talk about in this population is the CPAP or BiPAP issue. And I don't know how it plays into your decision about fundo versus GJ, but I think that's another really kind of important thing to think about, is how they receive their respiratory care, and does the amount of air potentially going into the GI tract change your equation?
Yeah, this is one of those reasons why the GJ, having the gastric venting sort of pop-off valve works so good, I think, sometimes in these kids.
So it sounds like in this patient population, we are generally in agreement that a Nissen or a fundoplication may not be the best option, that they are likely to have multiple things that may contribute to their symptoms and disease process and would require further workup, and GJ tube might be a better option in some incidences.
So our final patient is an 18-month-old toddler who is in your clinic, and he had a long gap esophageal atresia repair as a neonate. He has had 3 episodes of recurrent esophageal strictures, which have been successfully dilated with balloon dilators. He's now here in your office to see you because he's developed recurrent symptoms of dysphagia and vomiting of undigested foods. How would our panel like to manage this type of patient?
I can take the medical part out of the picture. For sure, you need some barium imaging to relook at that esophagus and the anastomosis. We would also think about esophageal motility. So dysphagia is complicated in nonverbal kids, and you have to figure out, is it liquid dysphagia? Is it solid dysphagia? Is it with both? Because it would change our evaluation. Dysphagia is not uncommon, and often there's delay in texture progression, and that may be totally okay and related to the dysmotility. So often we will think about an esophageal motility study if there's no stricturing of the esophagus. And then also from the GI perspective, when we think about dysphagia, not only do we see reflux esophagitis in these EA kids, but we also have a growing population of kids with eosinophilic esophagitis who also have EA. So as a gastroenterologist perspective, we have to rule out anatomic issues, we have to rule out motility issues, and we have to rule out inflammatory issues. And then lastly, the vomiting of undigested food. To me, I worry that the food is sitting in the esophagus, but we also do think about delays in gastric emptying. So I think we have a lot of homework to do before we would think of doing anything surgically in this kid.
Yeah, I agree. I think that first we're trying to understand the problem and what we're trying to fix, and whether this is related to the stricture getting worse and needing more sort of endoscopic therapy, advanced maneuvers such as steroids, incisional therapy, stenting, et cetera, or is this more related to reflux and failure to thrive from that? And particularly long gap esophageal atresia kids, very prone to have a hiatal hernia, depending on how that repair was performed, either with somewhat of a gastric pull-up or some sort of traction technique. That definitely is something to consider. They also may have a lot of associated respiratory issues and tracheomalacia, vocal cord issues, laryngeal clefts. And so I think all that needs to be evaluated. And so I think we usually start off with a sort of EGD, many times even a bronchoscopy, to kind of assess that in addition to the motility studies.
This is an extremely complex patient population, and outcomes after fundoplication are not great because of the motility issues in the esophagus. So if you go and do this in an esophageal atresia patient, you have a high failure rate in terms of recurrent reflux. And also you can get kids who have a worse problem after their fundoplication, in that it's too tight. Even if you do a partial wrap, it can be too tight, and they can have even worse swallowing problems. So it's a real challenge to make a surgical decision in these babies sometimes.
Yeah, I agree. And I think that speaks to the value of having multidisciplinary input into the care of these babies. And particularly, if your place has an aerodigestive center, that's really key to caring for these children and bringing all of these various viewpoints to bear.
Rachel, you mentioned barium study, whether it's upper GI, and then also a gastric emptying study. Are there any other studies that this patient population could benefit for before a surgeon makes a decision?
I mean, I think exactly what Ben said is like a multidisciplinary view of what's going on in the OR, I think is helpful. The endoscopy, the dynamic bronchoscopy, and the flexible bronchoscopy to get a sense of what's going on from a lung damage perspective, from a malacia perspective, and then from an inflammatory perspective. Again, we're lucky because we have motility at our center, so we tend to do esophageal motility early on in the diagnostic evaluation. Just like we have gastric emptying scans, we have esophageal motility studies that we use with nuclear medicine, where we give kids a nuclear tracer and we see where in the esophagus things are getting hung up. And that can often be helpful. Is it above the area of the anastomosis? Is it the distal esophagus where we have dysmotility? So sometimes even something simple like giving some nuclear tracer can help tease out where the problem is.
This is one area where we actually do have really good long-term outcome data. There's a lot of studies, at least 3 or 4 that have been coming out of Scandinavia and Finland. Some European consortia that are looking at adults who've had esophageal atresia, and they're finding significant incidence of dysplasia, Barrett's esophagus 30 years out. But here's what's interesting is it doesn't seem to be affected by whether they had fundoplication or not. So once again, we do something because we're trying to solve an immediate problem, But really, the problem we're trying to solve doesn't seem to be influenced by whether we protect against reflux or not protect against reflux, at least surgically.
And I think this is where that motility part becomes a big issue, right? Because if you can get with a Nissen down to, let's say, 10 reflux episodes per 24-hour period, but you can't clear those 10 episodes because you have no motility, it's a really big problem. And so to your point, I think, Tim, that you mentioned about doing fundos in when you have a dysmodal esophagus, it's a really big problem, not only from a dysphagia perspective, but then when you get acid in, it's really hard to get it out. So we often see lots of erosion sitting right over that fundo.
So I'm going to bring you guys back to probably what would be the most common scenario. So these are great that you have the ability to do these more sophisticated testing on the patients. I would guess that likelihood is if you had a patient who came in with a couple episodes of stricture, you dilate them, and then you're looking for what to do to try to minimize risk of this occurring again, and you do the manometry, likelihood is that they're going to have abnormal motility, but probably on some level there's a likelihood that they're going to have reflux as well. How do you then balance how to best care for these patients to protect their esophagus?
Yeah, so in the esophageal atresia guidelines that we drafted now several years ago, recurrent stricture was one of the indications for fundoplication. But to your point, it's exactly a balance where you have to really understand why that stricture is happening, and especially it's a long gap, right? So there's lots of different nuances there. And Ben, maybe you can talk a little bit about your experience with that.
Yeah, I think what we consider a refractory stricture, usually strictures that have been sort of endoscopically dilated with advanced sort of maneuvers such as steroids or incisional therapy or stenting, sort of 6-8 times if you've been dilating that anastomosis and it still strictures down, it's likely going to be a refractory stricture and it may need a resection. The challenging point is when you have an associated hiatal hernia with a stricture, what do you treat first? If you have a stricture that looks like it's going to need a stricture resection, and you also have a bad hiatal hernia, which one do you do first? And we really don't know. And we're trying to sort of tease that out. We have a significant proportion of patients who've had it both ways, and it's hard to know exactly where to go because you have on one side, you treat the stricture first, you may make the hiatal hernia worse by pulling on the esophagus. So the other way around, if you do the hiatal hernia first, then you may sort of affect the blood flow to the lower esophagus before your subsequent resection. And how much time do you wait for each of those approaches? So that is a challenging sort of idea for decision-making point. We're looking into that right now. We hope to share some of those results with our cohort in the near future. But to the other point of, so you have a refractory stricture and no hiatal hernia, I think that for sure is something that's a little easier to sort of make the decision-making to move ahead with the fundoplication in this patient population with the hopes of protecting that anastomosis against reflux. But again, I don't think we have convincing data to suggest that the fundoplication is going to save that anastomosis. In fact, our bias is usually that the writing's on the wall. That anastomosis is refractory regardless of your fundoplication or not. I think ultimately it may need stricture resection. We were very aggressive with sort of early stricture resections as opposed to, we have sometimes kids that come in and have had 50, 60 endoscopic dilations and people giving kids general anesthetics for dilations. And it's, sometimes it's an issue that just needs a stricture resection that, yes, they're not easy and it's a big operation, but it's often what is needed.
Well, let me ask about the type of fundoplication. I know that most of us would probably do a full Nissen wrap, but I think certainly room for discussion as to whether or not partial wraps were effective or not.
We also always try to strive for a full 360-degree wrap on these Nissen fundoplication kids. In fact, our data initially hasn't been published, but it would suggest that the few occasions, about sort of 10% of the time, we are unable to do a full 360 wrap, mostly from microgastria or kids who've had prior disasters with their stomach, that you just don't have enough stomach to do a full wrap. And those are the cases where we do sort of a partial wrap, either anterior or posterior, depending on surgeon preference and sort of anatomy concerns. And those have a high failure rate in our hands. And it's hard to tell whether a normal size stomach with a partial wrap would do better. But in our hands, when you're left with a small stomach that you can't do a full 360 wrap, that has a high chance of failure. And we sort of know that going into things, and we counsel parents. And some of those are those kids that we've had to do that and still are dependent on post-pyloric feeds because we just can't get them to be able to tolerate gastric feeds because their stomach is so small and the wrap isn't that great. with the esophageal atresia population, sort of Z line or endoscopic G junction is often not where you think it is externally. So we've been moving forward to doing a lot of these wraps endoscopically guided to mark what appears to be the endoscopic G junction or the Z line and do the wrap at that level. It ends up being higher than you think it is. So far, preliminary results would suggest that the rate of what we call wrap failure or meaning a recurrent hiatal hernia is better with that approach. But it's sort of hard to understand sort of why. I think there is a discrepancy in sort of that transition zone between what, as a surgeon externally, you would think is the G junction versus endoscopically, where is that transition? So that's an interesting feature we've found, particularly in the esophageal atresia population. So in a kid with esophageal atresia who is failing the conversion from a GJ to a G2, meaning they're wanting to progress with their oral skills and they don't have significant issues with vocal cord issues or other things, and they're making progress with their oral aversion, particularly the long gap kids who have significant oral aversion depending on the age that they're repaired. But if the failure of that progression appears to be reflux, that's when we would move forward this lymphadenoplasty. And for the most part, we're successful at moving them from, GJ to G feeds and tolerating gastric feeds, and that quickly turns into them being able to tolerate a lot more by mouth, as opposed to the stricturing. I think for us, the way we would see it would be the main indication is the inability to progress with oral feeds when there doesn't appear to be a anatomical reason for that from a sort of oropharyngeal problem, either oral aversion or vocal cord issue or a laryngeal cleft.